which program you will go and join, you will end up taking care of these patients. Inflammatory bowel disease, as we will walk through these slides, you will realize that it involves almost any organ from head to toe. So whether you are joining dermatology, you are joining surgery, you are joining medicine, or any program that you will join, you will end up taking care of these patients. And the more you know about these patients, you will be more comfortable talking to them. Even if you are not directly involved in their direct management, at least you will know what they have been through and what medications they get and what type of symptoms they get. And then if you need more information, I tweet, so you can see my Twitter account there as well. Follow me and I can keep teaching you on it. So there are a lot of objectives, and as I told you, that my goal today is that you learn at least one thing that you can take home and remember for the rest of your life. So pick your thing and then just remember that. So I will start with this question. You're reviewing a medical chart of a patient who recently underwent a colonoscopy for the evaluation of diarrhea. The report reads as diffuse inflammation of the colon involving rectum and entire colon. No skipped areas. Biopsies were done, and pathology report mentions diffuse mucosal inflammation of the colon. So the most likely diagnosis is, do you have these slides with you also? Yeah. Okay, so don't advance the slides. So we'll just make it interactive, okay, so that we learn. Most likely diagnosis is collagenous colitis, microscopic colitis, ulcerative colitis, or Crohn's colitis. Those who say collagenous colitis, raise your hands. Microscopic colitis, ulcerative colitis, Crohn's colitis. Okay, so those who said ulcerative colitis, why did you say ulcerative colitis?
No skip areas.
No skip areas, rectum. Okay. Those who said Crohn's colitis, why did you say Crohn's colitis?
Because it doesn't mention ulcers.
Doesn't mention ulcers? Okay. So that's very important, because just now we have a patient in the hospital who came to me and referred to me, and he was transferred to another facility with quote-unquote ulcerative colitis, because he had an endoscopy showing ulcers in the rectum and sigmoid cord. I just scoped him this morning to confirm his diagnosis, and he had ulcers in the ascending colon also, so he had skipped lesions. So when you have skipped lesions, that's Crohn's disease, not ulcerative colitis. So that's the clue to you that if you have skipped lesions, that's Crohn's disease. Okay? Ulcerative colitis means the mucosa is ulcerated. It doesn't mean that you have to see those ulcers. You can see inflammation, redness, but microscopically there will be ulcerated mucosa. So ulcerative colitis means that you have inflammation in the colon. Crohn's colitis means that you have inflammation in the colon, which are skip lesions, and we'll talk more about it. So this is ulcerative colitis because it's a diffuse inflammation. It involves rectum and entire colon, and it is a mucosal inflammation. So as we were talking about in Crohn's disease, you get skip lesions, it's not a diffuse inflammation, and you get more than mucosal inflammation. You get submucosal inflammation. So the inflammation actually trickles down the layers of your intestines and go deep below the mucosa also to submucosa. That's the classification of IBD. As you can see on your left side, there's microscopic colitis. Actually, it's the right side. Microscopic colitis, which is further divided into lymphocytic and collagenous. As the name implies, it's a microscopic inflammation. So if you have a patient, typically it's 50 or 60-year-old female presenting with watery diarrhea. That's a very typical presentation of microscopic colitis. Patient comes to you, and you will assess the patient, and you will write down, this is a 56-year-old Miss X having watery diarrhea for 2 years, had a colonoscopy that was negative. And you're wondering, what could this diarrhea be? So one important thing that you have to look is, did somebody do biopsies? Even if the colon was looking normal, did they do biopsies to rule out inflammation or microscopic inflammation. And then based on what type of inflammation, whether you see lymphocytes or more collagen band, you can then even further categorize them into lymphocytic and collagenous colitis. Intermediate colitis is a type of colitis where you cannot really very easily differentiate whether this is Crohn's disease or ulcerative colitis. That's called indeterminate colitis. Some people call it intermediate colitis also. Now, Crohn's and ulcerative colitis, actually they're called idiopathic inflammatory bowel disease. For the sake of discussion, we will call IBD, which will then means Crohn's disease and ulcerative colitis. So whenever I will say IBD from now onwards, we will mean Crohn's disease and ulcerative colitis. Just to let you know that there are other categories also, like microscopic colitis and indeterminate colitis also. Ulcerative colitis only involves the colon. Crohn's disease can involve colon. It calls Crohn's colitis. Or it can involve small intestine. Or it can involve both small and large intestine. Do you know who this person is? Do you know why Crohn's disease is called Crohn's disease? So that's Dr. Crohn's. So why was it named after Dr. Crohn's? So back in old days, in 1930s, there were 3 medical students, Crohn, Ginsberg, and Oppenheim. And there was a surgeon who had cases, about 100 cases of young kids that died because of inflammation in their terminal ileum. So he was suspecting that there is something going on. There's a chronic disease that is killing these people. So he asked his students to write a paper. So eventually, nobody knew who that surgeon was because he just disappeared. And these students became residents and then they published it. When they published the paper, these days, when you publish a paper, the first author is the one who worked really hard. The last author is usually who is your mentor. Back in 30s, it went by alphabets. So Crohn became the first author, Oppenheimer the second, Ginsberg the second, Oppenheimer the third. So Dr. Crohn got to present this paper on a podium in Mount Sinai Annual Conference. And ever since then, we started calling it Crohn's disease. So basically it was inflammation of the terminal ileum, which is the most common site of Crohn's disease, is a terminal ileum involved. But Crohn's and colitis are very old diseases. There is even a vague description of this type of colitis in one of the very first textbook of medicine called Yellow Emperor's Canon of Internal Medicine that was written 700 BC. And the classic description of Crohn's disease was first described in 1612. The classic description of ulcerative colitis was described in 1859. And there was a physician who was charged with the homicide of his maid. So it was thought that he poisoned his maid. And his maid got bloody diarrhea and then she died. Later on autopsy, it was found out that she had chronic inflammation of the colon. She was having bloody diarrhea because of ulcerative colitis. And that's where the classic description of ulcerative colitis came. This is how a normal colon looked like. As you can see here, blood vessels, shiny pink mucosa, normal colon. This is how your ulcerative colitis looks like. You see a lot of inflammation here, redness, loss of blood vessels. This is ulcerative colitis, where your inner mucosa is involved. In Crohn's disease, you have more than inner layer involved. So you see deep layers involved, fissures, ulcers, and that's how it looks like then, deep ulcers. So that's Crohn's disease. So this is your normal colon. Histologically, you can see the crypts, these are called crypts, lined by epithelium. So they are regularly spaced, but when you get inflammation, you get these branchings. The space between the crypts become irregular, and even with this branching, you can get inflammation and abscesses. So here you are seeing irregularly spaced crypts, normal colon. Here you are seeing irregularly spaced crypts and abscesses. So this is your normal colon, again, crypts, and this is your colitis. Now the question is what type of colitis this is. Is this Crohn's colitis or this is ulcerative colitis? We're seeing there's mucosal inflammation. When you do biopsies, you just do mucosal biopsies. You cannot do submucosal biopsies on endoscopy because when you do forceps biopsy, you just take the mucosa. So the question is whether this is Crohn's or ulcerative colitis. When you see granuloma, so whenever in your board questions, in your exam questions, whenever you see a description where it says granuloma, that's Crohn's disease. Crohn's disease has granulomas, remember that. So all the slides that have this little heart here are important slides. So when you're preparing for your exam, you can just go to these slides and look for this heart and just scan through that quickly. I think you will pass. So remember, granulomas in the colon biopsies are classic for Crohn's disease. So once again, the differences between ulcerative colitis and Crohn's disease. Crohn's disease is transmural inflammation, so more than just mucosa, and it has granulomas in it. So here this is superficial inflammation, here the inflammation is going deep. Every year, 30,000 patients are being diagnosed with Crohn's and colitis in the United States. So by the time you will graduate, there will be more and more people with this diagnosis. I remember when I came to Oklahoma in 2003, when I started my residency, we would hardly see patients in our clinic, maybe once a week, twice a week. And then when I was graduating in 2009, we would have 3 or 4 patients every day. And now I practice mostly IBD, and we see about 17 to 18 patients with Crohn's and colitis every day. So the incidence and the prevalence is increasing of Crohn's disease and ulcerative colitis. It's an expensive disease. The cost, the annual direct cost is about $6 billion. And that does not even account for indirect costs, loss of work, loss of job, loss of school. So it's a costly disease. You may have seen these type of slides for obesity, diabetes, where in the United States start with light blue and then everything become dark blue and red. Same thing happened with Crohn's and colitis. Started right up here in New York, Chicago, and then this is before 1960, before you were born, and this is 1980 and 2008, and you can see every state, even Alaska is red. So a lot of Crohn's and colitis that has happened. And why did that happen? So it makes you wonder, your genes don't mutate in such a short period of time. They don't mutate they take hundreds of years to mutate. So what else could have caused a rising incidence, prevalence of Crohn's and colitis? What is causing us to have autoimmune diseases? We probably would be seeing more kids with eczema, asthma, arthritis, and now Crohn's disease. What's happening? So if your neighbor asks you, well, you are learning medicine, and my family member had Crohn's disease, what could have caused him to have Crohn's disease? What would be your response?
Genetics.
Well, genetics, well, we just talked about, yes, genes are involved, and genes can cause, but what else can cause Crohn's and colitis? Environmental. What in environment? What? Pesticides, chemicals, so diet, hygiene, becoming super hygienic, paying the price of that. Inappropriate use of drugs, antibiotics, killing your gut bacteria. So lots of things that are happening. And all these things ultimately influence your gut bacteria. Anyone can guess how many gut bacteria we have in our intestine? Okay, let's start. Row 1 has only one person. How many gut bacteria we have? We'll just go and every row will guess. How much?
10 million.
10 million. Row 2.
100 trillion.
Row 3. 100 trillion. Row 3.
5 trillion.
5 trillion. Row, next row. Just guess. 5 trillion. Okay, next. Just guess. Yeah, you guys. Just guess. 80 million?
Yeah.
2.5.
So for each human cell, you have about 10 bacteria inside your gut. So you have more bacteria than your own human cells. And the rough estimate is 100 trillion. I think they were fast Googling, right? Okay, so these gut bacteria are in very fine balance. And if that balance gets disturbed, you can get a lot of consequences because of that. Genetic susceptibility, you talked about genes. Yes, genes are involved. Anyone can guess how many genes are there that have been involved in Crohn's and colitis? A lot. 200, yes. Okay, you are way ahead on the slides. You need to come back to the slide. Okay, immune response. So what happened is that when you have gut bacteria, which are potentially harmful, they are invading your intestines, and as a natural defense, your immune system will become activated because there will be signal going to them that there's something wrong happening. And as a result, they will try to kill that bacteria by releasing certain cytokines, certain inflammatory proteins. In a normal host, these proteins after a certain time will stop, they'll kill the bacteria, and everything will be reset back to normal, homeostasis. In Crohn's disease and ulcerative colitis, it doesn't happen. The turn on switch works, but the turn off switch is broken. So all these bacteria, when they go and invade, your white blood cells secrete these inflammatory proteins, and then they keep secreting it. They keep secreting it to the point where they start causing damage to the intestinal wall. And then you get chronic inflammation, and then it just never stops. So the trigger starts this immune response that never stops them. And then we talked about different environmental triggers that can cause this environmental effect. The first gene that was involved in IBD and thought to cause Crohn's disease was NOD2-CARD15 genes. It was a major landmark in IBD genetics, was the discovery of this gene in 2001. And how do genes interplay? This is, you don't need to remember this, but just to give you a concept of how gene, immune system, and bacteria interplay in your intestine. So this is your intestinal wall. This is your bacteria that has peptidoglycans wall. When the bacteria enters the intestinal wall, toll-like receptors take part of the protein. It goes and it triggers the inflammatory proteins like interleukin 12, NF-kappa B, and it causes inflammation. Part of that bacterial wall goes and cause this gene to become activated, NOD2-CARD15 gene. And what this gene then does, it suppresses the inflammation. It gives the signal to stop. So there is a feedback loop that happens where the inflammation happens, and then the gene, NOD2-CARD15 gene, is sending the signal to stop the inflammation. When you have a mutation in the gene where this LRR is missing, then what happens that you are unable to suppress this inflammation, and the process of inflammation just continues. So this is how gene, immune system, bacteria can cause problems in your intestine. So we talk about like how more than 200 genes are discovered in IBD now, so it's a very complex disease. Next question. 42-year-old white male present with a history of diarrhea off and on for 2 years. His symptoms are worse now with bloody diarrhea for 2 months. He described these symptoms as urgency and weight loss. He was recently diagnosed with ulcerative colitis. What will be an important clue in patient history, specifically regarding ulcerative colitis? Those who say, number 1, history of contact with sick person, history of travel to endemic area, IV drug use, smoking, cessation history, family history of colon cancer. Okay, so why did you say family history of colon cancer?
Recent change.
So, family history of colon cancer does increase your risk of colon cancer, right? But it doesn't increase your risk of colitis. So that was a distractor in the question. So colon cancer in the family does increase your risk of colon cancer, but not the risk of ulcerative colitis. Family history of ulcerative colitis does increase your risk of ulcerative colitis. There are studies that have shown a negative association between smoking and ulcerative colitis. Classic description. You stop smoking and you get ulcerative colitis. So the next time you see an ulcerative colitis patient and he tells you that he got diagnosed in 2009 with ulcerative colitis, you will look really smart if you say, let me guess, you quit smoking in 2008. Like, how did you know that? Because this is what happened classically in these patients. They quit smoking and they get the first attack of ulcerative colitis. But if they resume smoking back, they would not get cured. So this is just an association where smoking somehow was suppressing their colitis to get to the surface. But once it gets to the surface, resumption of smoking will not help. So we talked about environmental factors, genetic susceptibility, physical activity. Lack of physical activity can cause colitis. Appendectomy can cause Crohn's disease. So how many times in the past we would have surgeons going there and we'll just take the appendix out because, oh, we were just there and we'll just take the appendix out. So appendectomy in young kids, not because of appendicitis, then you need appendectomy. But appendectomy, electively having an appendectomy done does increase your risk of Crohn's disease. Just like smoking cessation increases your risk of ulcerative colitis. Stress can cause IBD. Vitamin D deficiency can cause IBD. Hygiene. So don't be super hygienic moms or siblings because it's okay for the kids to play in dirt. That's what they get homing, immune homing. So they get exposed to worms and germs. They get their immune system develop memory cells so that when they grow older, they're able to fight those infections. So if the kid is grown in a super hygienic environment, they're all the time the alcohol and other chemical hand sanitizers, not only they get exposed to this orally and can kill the good gut bacteria, but that can also influence their immune system. So it's okay for the kids. Now you don't want them to just get really dirty and play all the time and start eating dirt, but it's okay to be playing in the dirt. Diet. Highly refined sugars. Red meat does increase your risk of Crohn's disease by 3 to 4-fold. Lack of sleep can cause inflammation in your body. Medications. Kids exposed to antibiotics can get 4-fold increased risk of Crohn's disease later on in their life. And we talk about gut bacteria also. So how do Crohn's disease and ulcerative colitis present? Again, this is the same question stem where a 22-year-old with a diarrhea of 2 years, recently symptoms getting worse, now having more bloody diarrhea with urgency weight loss, got diagnosed with ulcerative colitis, which is not a typical feature of ulcerative colitis. What's not typically present in ulcerative colitis patients? Blood in stool, mucus in stool, abdominal pain, perianal fistula, ANCA positive. Okay, so they do have bleeding. They do have mucus in the stool because the epithelium is sloughing off. They do have abdominal pain because of inflammation. They don't have perianal fistulas because fistulas are present in Crohn's disease. Ulcerative colitis is a superficial mucosal inflammation. So it doesn't go deep, so it doesn't develop into fistulas. ANCA are positive in ulcerative colitis. ASCA is positive in Crohn's disease. You may get this question. P-ANCA in ulcerative colitis, ASCA in Crohn's disease. So this is a summary of the clinical features of ulcerative colitis and Crohn's disease. We have talked about it, that it's a continuous inflammation, starts from rectum, go all the way. Crohn's disease is patchy inflammation, skip lesions, transmural, full thickness inflammation. The most common site is terminal ileum. And which vitamin is absorbed in terminal ileum? B12. So, you can get a question, you can get a patient in your clinic where he or she may have manifestations of B12 deficiency, such as numbness and tingling. So you will wonder why they're having vitamin B12 deficiency. Could they have Crohn's disease? If a patient with Crohn's disease is presenting with numbness and tingling, you know that they may not be absorbing B12. And they may not be absorbing B12 because they may have active disease. It means they're not on the right medication. So vitamin B12 deficiency can be a big clue. Then they can also have extraintestinal manifestations. For example, in ulcerative colitis, if a patient presents with elevated liver enzymes, it can be primary sclerosing cholangitis. If they present with abdominal pain, flank pain, think of kidney stones also in Crohn's disease. So if a patient has Crohn's disease and now they are presenting with symptoms of kidney stones or flank pain, sharp pain, and you wonder they are on a good medication with Crohn's disease, why they're still hurting, why they're still having abdominal pain, pause and think, could they have kidney stones? Because they can get calcium oxalate stones. Once again, ulcerative colitis, you can see it's a continuous disease from rectum going up. Crohn's disease, patchy, transmural, so you can even develop strictures. Now, here you can see specimen, terminal ileum, inflamed. Crohn's disease typically involve small and large intestine, terminal ileum, cecum, most common site, but you can have Crohn's disease of duodenum. I have seen Crohn's disease of esophagus, oral cavity. Crohn's disease can happen in your skins also. So Crohn's disease can involve different organs of your body. Typically, Crohn's disease presents with abdominal pain. This is how a perianal fistula looks like. These are openings, abnormal openings from the rectum to the skin. Typically, patients complain that they are having a lot of tenderness around their rectum or perianal area. They get a lot of fecal swelling because the feces track to this and come out. So pain and drainage is the most common symptom of perianal fistula. So you may want to ask this question if you see a patient with Crohn's disease. Do you have rectal pain? Do you have any drainage? The answer is yes. You may want to get some kind of a CAT scan or an MRI to make sure they're not having perianal fistula. This is how a fistula looks like. Ulcerative colitis typically presents with diarrhea and urgency. And tenesmus. Do you know what tenesmus is?
Yes. It's like dry heat.
Okay, so now, if a patient comes to you and patient is asking you, what is tenesmus that you just asked me? What would you say?
It's like dry heaving of your butt.
Now the patient is saying, I don't understand what you're saying. How would you explain that?
When you push and push, but nothing seems to come.
Yes, yes,
You
yes.
feel it.
No, yeah, that's okay. You can say dry heaving of the butt, but some people don't like that description. But it is a classic description. This is how classically you describe it. And you both are right. This is good. Because last year I shared the story that I was using this word tenesmus all the time until one patient asked me, what is tenesmus? And I was like, I don't know. I had to really go back to Oxford Dictionary and look for tenesmus and learn myself. And that's not too long ago. So that's how I learned. And then I changed the way I asked the question about tenesmus. So I write in my note, patient is having tenesmus, but I ask them exactly the same way you're asking. So I ask them, the way I ask them is that when you go to the bathroom, have a bowel movement, and you come back and you feel like you need to go back again. So it's the same thing as you guys are describing. But I don't say you are having dry heat. But it's a classic way to understand. So the Crohn's and colitis can present differently. Not all Crohn's and colitis are same. You can see their disease behavior. They can have severe disease and they get better. They can have severe disease and they never get better. They are better and then all of a sudden they get worse. And then they go for surgery, boom. Or they have this roller coaster. They get better, they get hospitalized. They get clear, they get better. So disease behavior is different in different people. But what happened is that you need to understand this concept because that's how you treat Crohn's disease now. You're seeing this graph going up and down, up and down. Patient is presenting to you that I'm having a flare, you give them steroids, you give them medication, patient got better. He comes back to you saying I'm having a flare, you give them medication, they get better. So it's kind of like horizontally timeline, you're following that patient. But you're failing to understand that with this time, there is something that is accumulating, and that is structural damage. And because of that, they will end up having surgery. Because now they're developing stricture and fistulas. So the important concept of treatment nowadays is that you hit, and you hit hard in the beginning, so that you can bring this other graph down and minimize the risk of surgery. Because the risk of surgery in ulcerative colitis in 10 years is about 30%. And you want to minimize that risk to your patients. So when you tell your patients, your risk is about 30% that you will have surgery in 10 years. And I'm offering you these medications with the hope that we will heal you and bring that risk from 30% to 20% to 10%. But in general, your risk is about 30%. Crohn's disease is transmural disease, a lot of disease. So their risk of surgery, as you can see here, is about 80% in 10 years. So you have to tell them that we have to be very aggressive in controlling your disease, because if you don't control, you will have 80% chance that you will end up having surgery in 10 years.
I have a question.
Yes?
Are those risks if they're untreated?
It's an overall risk.
Overall, treated and
Treated and untreated. Like the overall risk of Crohn's disease patients having surgery, because until recently, this is what was happening. You were treating them, but they were getting this bowel damage accumulated. And that's how we calculated the risk of surgery.
Thank you.
And we want to minimize this risk now, because we want to bring this graph down now. 2-year-old boy presents with bloody stool, endoscopy showing inflammation. Which of the following is the clinical presentation of IBD in children? Blood in stool, diarrhea, failure to grow, fever, 1, 2, and 3, or all of the above. As we all know that whenever there is all of the above option, we have to choose that and move on. So yes, The key thing here is not this question, but to recognize that fever can be the manifestation of IBD in kids. So if the kids are having, if you see a patient, a young kid who's having fever, and all the workup is negative, think about Crohn's disease or ulcerative colitis. That they can have Crohn's disease. And I have few patients in my practice whose initial presentation was just fever. And that's it. They were just having fever, and eventually they got scoped and found out that they had small bowel Crohn's disease. They got treated, and their fever got better. I'm going to skip this slide, but for this, I left this slide for you that if you are really interested in pathophysiology of each symptom, like why do people get diarrhea, why do they get pain, why do people get fever, why do people get anemia, this is the explanation of those in Crohn's and colitis also. Extra-intestinal manifestation of IBD. So as I said, that it can involve anything from hair to toe. It can involve skin, eyes, bones and joints, kidney, and liver and bile duct. What's this? Classic skin lesions in ulcerative colitis. It is called Pyoderma Gangrenosum. Even the word tells you that. So sometimes in exams you can get a picture like this and you have to pick what this thing is or what the association is. It's ulcerative colitis, pyo, pus, derma, skin, gangrenosum, gangrene, right? So it's, you can see that there's pus, gangrene, skin lesions. Pyoderma gangrenosum. These are erythema nodosum. So red nodules, tender. You see on your lower legs. Very common in Crohn's disease. It gets better when you treat Crohn's disease. So if you are joining dermatology, you'll get these two skin lesions. If you're going to internal medicine primary care, you will see these patients with skin lesions. You don't need to remember this at all. This is very complex, but I want to introduce this concept of where the drug, which is used to treat psoriasis, can also cause psoriasis as a paradoxical reaction. So Humira, anti-TNF drug, it is used to treat psoriasis. Remicade, which is infliximab, is used to treat psoriasis. But in Crohn's and colitis patient, it can cause psoriasis. So it's called paradoxical reaction to an IBD therapy. So if your patient presents with these scaly rashes, these are psoriasis. Now, IBD patients can get psoriasis, and that psoriasis can get better with anti-TNF therapy. But if someone is on anti-TNF therapy and get these lesions, so this is called paradox, they're getting psoriasis. Okay, we'll move to this slide now. So how do you assess inflammation? In clinical trials, you assess disease activity through Crohn's disease activity index. In clinical practice, you do lab work. So if your patient is having high white blood cells, if your patient is having elevated CRP, if your patient is having stool lactoferrin positive, and these days we also do stool calprotectin, which is also a protein in the stool. Or you do IBD serologies. Talk about P-ANCA in ulcerative colitis, ASCA in Crohn's disease. So if these things are elevated, your suspicion of active disease becomes high. Then you need to evaluate them, you need to treat them for their active disease. So these are the markers of inflammation. Because your IBS patient can also present with abdominal pain and diarrhea. So how do you differentiate IBS and IBD? So when I started at OU and we had our first IBD Center of Excellence, and I was getting a logo for IBD Center of Excellence, sent it to the marketing team, and they wrote down IBS Center of Excellence. So that was like, I was really mad because IBD and IBS are different. And many physicians also sometimes get confused. They call IBD IBS and IBS IBD. IBD is what we are talking today. Crohn's disease and ulcerative colitis. IBS is irritable bowel syndrome, where you have symptoms without inflammation. And how do you differentiate? you will not see inflammation. You won't see all these markers of inflammation being elevated in IBS. Even if they're having a flare, you won't have leukocytosis. You won't have CRP elevated. You won't see stool WBC, stool lactoferrin elevated. And you won't see inflammation on imaging. So this is called CT enterography, which is another name for CT abdomen, which is done through a different protocol. So in my facility, we do this specialized CAT scan called CT enterography, which look at your small intestine. You can see here, this is your small intestine. You see this small bowel, you see the wall here, and compared to this, you see the inflammation here in terminal ileum. That how it's lightening up. So that's how you differentiate that your small bowel is inflamed. But how many times you can do a CT scan on a patient? There's a risk of exposure of radiations also. So then what you do is you do MR, enterography, which even gives you a better picture. But the problem is it's expensive and not many places can do MR. But that's a preferred test because of less exposure to radiation. So if you have a young female, you may want to consider doing MRI abdomen for their Crohn's disease rather than CAT scan. Because not only that MRI abdomen will tell us that patient has active disease in future. If you have to compare, you will just do MRIs. So even if she becomes pregnant, you can still do an MRI and compare whether she has active disease or not to the previous MRIs. Okay, we are moving towards the last section of our talk. And I told you that I'm going to finish in 1 hour because that's a condensed information. Everything is in your slides. You can review your slides again, but just pick one thing that you're going to remember, okay? So what are goals of our therapy? And I'm going to ask you what you picked at the end. So what are our goals of therapy? Not only you want your patient to be symptom-free, you want the mucosa to heal also. And why do you want that? You want that so that they don't get structural damage. You want that so that they don't end up having surgery. You want that because you want that 80% risk of surgery in Crohn's disease to come down. You want that so that you can decrease their hospitalization because we all talk about cost of care these days. So we need to reduce the healthcare cost in these patients. So it's important that you understand the goals because then you will pick the right medication for that patient. This is the history of how we used to treat IBD and where we have arrived now. We have even tried boric acid enema in these patients. We have even tried silver nitrate enemas. There were studies done where they thought that, you know what, they quit smoking, they get colitis, so what if we give them nicotine enemas? That failed too. 1950s got steroids. 1970s we got mesalamines. In 2000 we got anti-TNF therapies. And just recently, last year, we got anti-integrin and anti-interleukin 12 and 23 also. So we have made a lot of advancements because we know that not all patients can secrete TNF alpha and would benefit from anti-TNF because 200 genes, a lot of immune system problems, and one person can have interleukin 12 elevated causing inflammation, one person can have TNF alpha causing inflammation. So now we have a variety of drugs. So if anti-TNF is not working, you can use anti-integrin. And one of the anti-integrin that is available is vedolizumab, Entyvio. And in anti-1223, one of the anti-1223 that's available is called ustekinumab or Stelara. You have heard the commercials for Stelara and Entyvio. So how do we choose different drugs? We choose immunosalicylates, which are sulfasalazine and mesalamines. They work topically. They work only on the mucosa. So they are good drugs for what? And they are bad drugs for what? So if you ever see a Crohn's patient on mesalamine, you need to tell the patient, go change your doctor. because that's not the treatment in 2018. Mesalamines work topically. And throughout this lecture, I have stressed to you that Crohn's disease is transmural disease. If you treat this part, you will leave this part untreated, and it will form what? Stricture. And that's how you get stricture in Crohn's disease. So you need to give them highly effective medications. So you give them anti-TNF, you give them immune modulators, Imuran, 6-MP, azathioprine, tacrolimus, but not mesalamine. Steroids are good for short term, as a bridge. If someone is coming flaring up, you give them steroids, but then you make a plan to put them on something else. Why steroids are bad? So each row will tell me one bad side effect of steroids. So why steroids are bad? Unfortunately, you are the only one in this room. Why steroids are bad? So what would you tell a patient? Don't take steroids long term because it does what? Anything. Why steroids are bad? Okay, pass. You come back, you will remember. Okay, why steroids are bad? Osteoporosis, bone loss. Why steroids are bad? Immune suppression. We want them to get immune suppression. But why they're bad? Yes, it can cause stomach ulcers, yes. What does immune suppression can do? What's this bad effect of immune suppression? Infections. You can get infections. Many people who are on steroids get candida. Very common infection. UTI, very common. What else? What else steroids can cause? What?
Hunger?
No. Hunger, yeah. Appetite, weight gain, moon phase, high blood sugar, hyperglycemia, diabetes, cataract,
Can it suppress like the adrenal gland?
adrenal gland suppression. Yes, then you get steroid withdrawal. What else? Skin, papery skin, thinning of the skin, acne, mood changes, steroid psychosis, sleep disturbances. You can't sleep on steroids, and but you covered most of it. Myopathies, especially proximal muscle myopathy. Many patients who are on steroids for a very long time, you would notice in the clinic they would have hard time getting up because their muscles are weak. Proximal myopathy. So a lot of steroid side effects. So that's why you don't want to use them long term. So in our practice, if we have a patient who has used steroids for 2 times in a year, that's a red flag for us. We're not doing good. Why this patient is getting on steroids again and again. It means we are not on an effective therapy. But if he is or she is on effective therapy, maybe this patient needs surgery because steroids are going to cause more problems. Antibiotics, we use these antibiotics if they have fistulas, if they have infections because of Crohn's disease. The mainstay is immune modulators. 6-MP is azathioprine, methotrexate, anti-TNF drugs, such as infliximab, which is Remicade, adalimumab, which is Humira, certolizumab, which is Cimzia, and then anti-integrin therapy, such as vedolizumab, which is Entyvio. And then you have to give them supportive therapy. If they're having diarrhea, you give them antidiarrheal. This disease really makes people depressed and stressed out. Imagine 30-year-old telling them that you got Crohn's disease, that you're going to have for the rest of your life, and there's no cure for it. That's pretty stressful. And so we need to assess them for depression, anxiety, and stress, and offer them supportive care and supportive therapy. Same patient that we have been talking for the last 1 hour started on the treatment for ulcerative colitis. 15 years later, he developed cataract. Which of the following drug is the potential cause of his cataract? Mesalamine, steroid enemas, budesonide, prednisone, metronidazole. Why not steroid enemas? because they're topical, right? Do you know what budesonide is? It's a topical steroid. So it works only in the intestine. It has a very 90% or 99% first pass metabolism in the liver. So it's a steroid that works in your gut. So it's a good bridge for your Crohn's disease, especially when you have small bowel Crohn's disease. But you're all right. It's the prednisone that can cause cataract. I have reviewed lawsuits where patients have had side effect of prednisone, and they have sued their physician saying that they did not disclose that they can have side effects. I am aware of a chef in New York who got hip fracture and he could not continue cooking because he was put on steroids for long term because of the IBD. So he sued. I think it was a $100 million lawsuit. One patient got bilateral osteonecrosis, a hip joint, because of steroids. So lots of side effects that not only you need to be aware of, you need to make sure you disclose these side effects to the patients, because some of your patients really want to be on steroids, and you want to get them off of steroids for all these reasons. We talked about osteoporosis briefly, that steroids can cause osteoporosis, but remember, in Crohn's and colitis, osteoporosis can be caused for many other reasons. Malnutrition, these patients are malnourished. They have relatively low BMI. They may have malabsorption of vitamin D. They may be immobilized because they're sick, bedridden. Hypogonadism is common in IBD. Smoking can cause osteoporosis. And then chronic inflammation itself can lead you to have osteoporosis. There are risks of cancers in IBD. Colorectal cancer. If you have chronic inflammation, that does put you at risk for colon cancer. So if you have long-standing ulcerative colitis for more than 8 to 10 years, these patients need annual colonoscopy to screen for colon cancer, because chronic inflammation does put them at risk for colon cancer. And that's one of the educational points I try to deliver to my patients, that you don't want to get the treatment because you are worried about the risks and the side effects of the treatment. But just be careful and make sure that you understand, if you don't get treatment, the untreated and inflamed colon will put you at risk for colon cancer also. If you get treatment and you get immunosuppression, you can get increased risk of cervical dysplasia in females. So having a regular pap smears become very important in females who are on immunosuppression. So we need to talk about that to our females. Lymphoma risk is also common in patients who are on immunosuppressive drugs. We talk about colon cancer risk in IBD. So longer duration of disease, greater extent of disease will increase your inflammatory burden, will put you at increased risk. Family history of colon cancer will increase your risk of colon cancer. Primary sclerosing cholangitis. So if your patient with ulcerative colitis is having elevated liver enzymes, they can have primary sclerosing cholangitis. If they get diagnosed with primary sclerosing cholangitis, what's the next step? You get them a colonoscopy. Because now you know that primary sclerosing cholangitis increases the risk of colon cancer. And we talk about inflammation. Thromboembolism, very common. Increased inflammation, steroid use, immobilization increases your risk of thromboembolism. I have seen patients with cerebral stroke because of thromboembolism, seen patients with bilateral pulmonary embolism, seen patients with MI, seen patients with DVTs, because of the increased Crohn's disease burden, or increased inflammatory burden. I wrote this book a few years ago. So feel free to read this book. It's available on Kindle also. And I'm very proud, not that I just wrote down this book, but someone from Oklahoma wrote down this book.
Yeah.
Because when you see this Crohn's, when you see these books for dummies, the authors will be from where? New York, Chicago, right? Big names. So someone, a little doctor from Oklahoma, wrote a book, Crohn's and Colitis for dummies. So I'm very proud of that. And it's a very reasonably priced. I think it's like $13, $9 or $10 for Kindle version. But I wrote down this book, 365 pages approximately. I was writing one page every day. And I would go home and I would reflect, what did I talk to my patient today? What did I learn today from my patient? Or what did I tell my patients today? And I would write down this book. And you know, English is not my native language, so this page would go to 3 editors. And these 3 editors would make sure that the language is cut down to an 8th grade level English. And in this process, I learned something very new, communication, and how you talk to your patient. Telling them you have inflamed colon. Many patients don't even know what inflammation means. Telling them that you have Crohn's disease and I'm going to put you on an anti-TNF drug. It's very hard for a patient to understand. And another story that I tell you, because it's important for all of you to understand the importance of communication and how you talk to the patient. Especially when you get the newly diagnosed, you can zone out. Can I give a personal example? I went to get an opinion about like LASIK. And I was all well prepared. Oh, I'm going to get my glasses off, I'm going to swim, and no glasses, I'm going to go. My friend got LASIK. I'm going to go talk to this eye surgeon, and he's going to schedule me for LASIK surgery. Most of the patients, when they come, they have these expectations that I'm diarrhea, my doctor is going to fix me, I'll be fine. That's the expectation from when a patient comes to you, and I'm going to get better, and that's why I'm going to my doctor. So that was my expectation. I went to this eye surgeon. So I entered the room, comes to me, they did some fancy tests, and then he started talking about, you got keratoconus, you got this, you got cross-linking, and you're going to do this. And I just completely zoned out. Even being a physician, I could not understand what he was telling me. Not only he was using a medical jargon that I had no clue what keratoconus is, and my next thing was, when can he stop and I can Google and see what keratoconus is? I had no clue. And I was frustrated, I was zoned out, and I could not understand him, but he was talking to me for 15 minutes. So that made me realize, I entered the room, I talked to my patient that you have Crohn's disease, I'm going to start you an anti-TNF. They probably are zoned out, they have no clue what I'm talking about. So this book and this experience really helped me understand the power of communication and how you develop a relationship with your patient. You just need to talk to them in simple, plain English. Boil down, come to their level. Now there will be patients who will still not understand, but most of the people will like you to talk to them in their own terms. And then I tweet about Crohn's and colitis all the time. And one of the pinned tweet that is on my Twitter is, heavy early steroid use in IBD increase the risk of surgery. Because what we are doing with steroids, you are masking them with you're just masking their symptoms. You're making them feel better, but you're not treating their inflammation. And that's why they end up having surgery, more surgery. So high yield stuff. In the last 1 minute, I will wrap it up very fast, that you need to remember. Crohn's disease, transmural inflammation. Risk factor, family history, Ashkenazi Jews, and that's why you recall one of the slides that I showed you, it was in New York and Chicago, because that's where the Jewish population was heavily, they were populated in the 60s. Common manifestation, abdominal pain, diarrhea, oral ulcers, perianal fistulas, B12 deficiency, we talk about this. Erythema nodosum, we talk about this painful red nodule. Prednisone only for acute flare, anti-TNF for perianal fistulas. Treatment of choice. Ulcerative colitis, superficial, mucosal inflammation, starts from rectum and goes upward. You can have backwash uveitis. A little bit of terminal ileum will get involved because the colitis is just going all the way to the cecum and maybe a little bit in the terminal ileum. Bloody diarrhea, urgency, common symptoms, mesalamine. You start with mesalamine. If you don't treat, they can get toxic megacolon. And they also have increased risk of colon cancer. Last question. 34-year-old male with Crohn's disease present with recent onset of abdominal pain in periumbilical region, weight loss, and fever. He has a palpable mass on the right side. What's the next step? Give him steroids? Give him methotrexate? Do plain film x-rays? Do a CT scan? Call the surgeon. CT scan. It could be what? Abscess. It could be inflammation. It could be stricture. It could be active Crohn's disease. You need to know before giving them any medication. These are high-yield images. You see these deep ulcers and cobblestoning. This is called cobblestoning of Crohn's disease. This is normal colon diameter. Here, this. This is toxic megacolon. With that, thank you for your attention.
Thank you.
So what did you learn?
IBD and IBD are the same.
Yeah, they're different.
The what?
IBS and IBD are not the same.
Exactly, that is correct. That's a very important point to remember. Because many times I get consults, it says patient has IBD. And when we look, evaluate, everything is fine, we find out what you meant was IBS, not IBD. So it's important to distinguish between the two. One has inflammation, markers of inflammation will be elevated, and one is only symptoms. What else did you learn?
Crohn's is transmural.
Good, great.
Don't treat topically.
Don't treat topically, yes. What else?
Don't use long-term corticosteroids.
Exactly. Very important clinical tip. Do not use steroids long term. What else?
MRI instead of CT on a pregnant woman.
Yeah, preferable MRI for risk of exposure, but remember it's costly and it's not available everywhere. So whenever you get a chance, do an MRI. What else?
Crohn's can present clinically in lots of manifestations and lots of different systems and whatnot. From
Yes, Crohn's
head to
disease.
head.
Yes, and Crohn's disease. You can have oral ulcers. Think of Crohn's disease. You can have uveitis and abdominal pain. Think of Crohn's disease. You can have skin lesions and abdominal pain. Think of Crohn's disease. You can have lupus and abdominal pain. Think of Crohn's disease. You can have rheumatoid arthritis, psoriasis, now abdominal pain, diarrhea. Think of Crohn's disease.
And granulomas.
And granulomas on the biopsies. Crohn's disease.
Get psoriasis.
You can get psoriasis in IBD, and you can get psoriasis with the treatment in IBD.
Fistulas are Crohn's.
Fistulas are Crohn's. Fistulas are not present in ulcerative colitis. Perianal fistulas can cause symptoms of rectal pain, perianal pain, drainage, swelling, and you do CAT scan, find those tracts, and then you give them anti-TNF therapy. Okay, I think that was enough. Thank you